The parathyroid glands are endocrine glands that are located posterior to the thyroid gland. They produce parathyroid hormone, which is the main regulator of calcium physiology. The parathyroid hormone acts on three major organs, the bone, kidney, and intestine to maintain the extracellular fluid concentration within a narrow normal range. The hormone acts directly on bone and kidney and indirectly on the intestine through its effect on the synthesis of 1,25-hydroxy-vitamin D to increase the serum calcium level. In turn, the parathyroid hormone production is closely regulated by serum calcium concentration. This feedback system is the critical homeostatic mechanism for maintenance of extracellular fluid calcium level. Any tendency toward hypocalcemia is counteracted by an increased secretion of parathyroid hormone. Hypercalcemia can be a manifestation of a serious illness such as malignancy or can be detected incidentally by laboratory testing in a patient with no obvious illness. The causes of hypercalcemia are numerous, but primary hyperparathyroidism and malignancy accounts for 90% of all cases. Before undertaking a diagnostic workup, it is essential to be sure that true hypercalcemia and not a false positive laboratory test is present. Whenever hypercalcemia is confirmed, a definitive diagnosis must be established. Primary hyperparathyroidism is still the most common cause of hypercalcemia, followed by malignancy. Clinical features are helpful in the differential diagnosis of hypercalcemia. Hypercalcemia in an adult who is asymptomatic is usually due to primary hyperparathyroidism. In malignancy-associated hypercalcemia, the disease is usually not occult. Rather, symptoms of malignancy bring the patient to the physician, and hypercalcemia is discovered during the evaluation. In such patients, the interval between detection of hypercalcemia and death, especially without vigorous treatment, is often less than 6 months. Accordingly, if an asymptomatic individual has had hypercalcemia or some manifestation of hypercalcemia such as kidney stone for more than 1 or 2 years, it is unlikely that malignancy is the cause. Hypercalcemia from any cause can result in fatigue, depression, mental confusion, anorexia, nausea, vomiting, constipation, reversible renal tubular defects, increased urine output, a short QT interval in ECG, and in some patients, cardiac arrhythmias. There is variable relation from one patient to the next between the severity of hypercalcemia and the symptoms. Generally, symptoms are more common at calcium level more than 2.9 to 3 millimole per liter, but some patients, even at this level, are asymptomatic. When the calcium level is more than 3.2, calcification in the kidneys, skin, vessels, lungs, heart, and stomach occurs, and renal insufficiency may develop, particularly if blood phosphate levels are normal or elevated due to impaired renal excretion. Severe hypercalcemia, usually defined as level more than or equal to 3.7 to 4.5 millimole per liter, can be a medical emergency because coma and cardiac arrest can occur. Acute management of the hypercalcemia is usually successful. The type of treatment is based on the severity of the hypercalcemia and the nature of associated symptoms. Mild level can be managed by hydration, while severe and life-threatening hypercalcemia needs aggressive management and may require emergency measures. Shown to you are the different therapies for severe hypercalcemia. Most useful therapies include hydration, forced diuresis, pamidronate, solangenate, and denosumab. Special use therapies can be by calcitonin, phosphate, glucocorticoids, or even dialysis. Hyperparathyroidism. Primary hyperparathyroidism is a generalized disorder of calcium, phosphate, and bone metabolism due to increased parathyroid hormone secretion. The elevation of the circulating hormone usually leads to hypercalcemia and hypophosphatemia. The annual incidence of the disease is calculated to be as high as 0.2% in patients more than 60 years of age, with an estimated prevalence including undiscovered asymptomatic patient of 1%. Disease has a peak incidence between the third and fifth decades but can occur in young children and in the elderly. Parathyroid tumors are most often encountered as isolated adenomas without other endocrinopathy. They may also arise in hereditary syndrome such as multiple endocrine neoplasia syndromes. In a majority of cases, a single abnormal gland is the cause of primary hyperparathyroidism. The abnormality is usually a benign neoplasm or adenoma and rarely a parathyroid carcinoma. Some surgeons and pathologists report that the enlargement of multiple glands is common. In about 15% of patients, all glands are hyperfunctioning. Hereditary hyperparathyroidism can occur without other endocrine abnormalities but is usually part of a multiple endocrine neoplasia syndrome or hyperparathyroidism Joe tumor syndrome or non-syndromic familial hyperparathyroidism. Adenomas are most often located in the inferior parathyroid glands, but in 6 to 10% of patients, parathyroid adenomas may be located in the thymus, the thyroid, the pericardium, or behind the esophagus. Chief cells are predominant in both hyperplasia and adenomas. With chief cell hyperplasia, the enlargement may be so asymmetric that some involved glands appear grossly normal. Adenomas usually are around 0.5 to 5 grams in size but may be as large as 10 to 20 grams. Parathyroid carcinoma is often not aggressive. Long-term survival without recurrence is common if at initial surgery the entire gland is removed without rupture of the capsule. Recurrent parathyroid carcinoma is usually slow-growing with local spread in the neck, and surgical resection of recurrent disease may be feasible. Occasionally, however, parathyroid carcinoma may be aggressive and may metastasize at the lung, liver, and the bone. It may be difficult to appreciate initially that a primary tumor is carcinoma. Increased numbers of mitotic figures and increased fibrosis of the gland stroma may precede the invasion. The diagnosis of carcinoma is often made in retrospect. Hyperparathyroidism from a parathyroid carcinoma may be indistinguishable from other forms of primary hyperparathyroidism, but is usually more severe clinically. A potential clue to the diagnosis is offered by the degree of calcium elevation. Calcium values of 3.5 or more are frequent with carcinoma. Many patients with primary hyperparathyroidism are asymptomatic. Manifestation involve primarily the kidneys and the skeletal system. Kidney involvement due either to deposition of calcium in the renal parenchyma or to recurrent nephrolithiasis. Renal stones are usually composed of either calcium oxalate or calcium phosphate. In occasional patients, repeated episodes of nephrolithiasis or the formation of large calculi may lead to urinary tract obstruction, infection, and loss of renal function. The distinctive bone manifestation of primary hyperparathyroidism is osteitis fibrosa cystica. Histologically, the pathognomonic features are an increase in the giant multinucleated osteoclast in scallop areas on the surface of the bone and a replacement of the normal cellular and marrow elements by fibrous tissue. X-ray changes showed subperiosteal resorption. However, in recent years, osteitis fibrosa cystica is very rare in primary hyperparathyroidism, probably due to the earlier detection of the disease. In symptomatic patients, dysfunction of the CNS, peripheral nerve and muscle, gastrointestinal tract, and joints also occur. It has been reported that severe neuropsychiatric manifestation may be reversed by parathyroidectomy. When present in symptomatic patients, neuromuscular manifestation may include proximal muscle weakness, easy fatigability and atrophy of muscles, and may be so striking so as to suggest a primary neuromuscular disorder. The distinguishing feature is the complete regression of neuromuscular disease after surgical correction of primary hyperparathyroidism. Gastrointestinal manifestations are sometimes subtle and include vague abdominal complaints and disorder of the stomach and pancreas. Again, cause and effect are unclear. Pancreatitis has been reported in association with primary hyperparathyroidism, but the incidence and the mechanism are not established. Asymptomatic primary hyperparathyroidism is defined as biochemically confirmed hyperparathyroidism with the absence of signs and symptoms typically associated with more severe form of primary hyperparathyroidism such as features of renal or bone disease. Much attention has been paid in recent years to the manifestation and optimal management strategies for asymptomatic primary hyperparathyroidism, as this is now the most prevalent form of the disease. Following are the criteria for surgery in asymptomatic primary hyperparathyroidism. Serum calcium of more than 1 mg per deciliter above the normal value, creatinine clearance less than 60 ml per minute, 24-hour urine for calcium more than 400 mg per day, and increased stone risk by biochemical stone risk analysis or presence of nephrolithiasis or nephrocalcinosis, evidence of osteoporosis or vertebral fracture, and less than 50 years of age. The current consensus is that medical monitoring rather than surgical correction of primary hyperparathyroidism may be justified in certain patients who are asymptomatic. The current recommendation is that patients who showed mild disease, as defined by not meeting the different criteria for surgery, can be safely followed under management guidelines. The diagnosis of primary hyperparathyroidism is typically made by demonstrating an elevated immunoreactive parathyroid hormone level in a patient with hypercalcemia. Serum phosphate is usually low but may be normal, especially if renal failure has developed. Surgical excision of the abnormal parathyroid tissue is the definitive therapy for this disease. Two surgical approaches are generally practiced: the conventional parathyroidectomy procedure, which is a neck exploration with general anesthesia, and an outpatient procedure with local anesthesia termed minimally invasive parathyroidectomy. Recently, there has been growing experience with new surgical strategies that features a minimally invasive approach guided by improved preoperative localization and intraoperative monitoring by parathyroid hormone assays. Severe hypercalcemia may provide a preoperative clue to the presence of parathyroid carcinoma. In such cases, when neck exploration is undertaken, the tissue should be widely excised. Care is taken to avoid rupture of the capsule to prevent local seeding of the tumor cells. A decline in serum calcium occurs within 24 hours after successful surgery. Usually, blood calcium falls to low normal values for 3 to 5 days until the remaining parathyroid tissue resumes full hormone secretion. Acute postoperative hypocalcemia is likely only if severe bone mineral deficits are present or if injury to all the normal parathyroid gland occurs during surgery. The extent of postoperative hypocalcemia varies with the surgical approach. Medical monitoring rather than corrective surgery is still acceptable, but it is clear that surgical intervention is the more frequently recommended option. When surgery is not selected or not medically feasible, there is interest in the potential value of specific medical therapies. There is no long-term experience regarding specific clinical outcomes such as fracture prevention, but it has been established that bisphosphonates increase bone mineral density significantly without changing serum calcium. Calcimimetics that lower parathyroid hormone secretion lower calcium but do not affect the bone mineral density. Hypercalcemia due to malignancy is common, occurring in as many as 20% of cancer patients especially with certain types of tumors such as lung carcinoma. It is often severe and difficult to manage, and on rare occasion difficult to distinguish from primary hyperparathyroidism. Histologic character of the tumor is more important than the extent of skeletal metastasis in predicting hypercalcemia. Small cell carcinoma and adenocarcinoma of the lung, though the most common lung tumors associated with skeletal metastasis, rarely cause hypercalcemia. By contrast, many patients with squamous cell carcinoma of the lung develop hypercalcemia. Hypocalcemia. Chronic hypocalcemia is less common than hypercalcemia. Causes include chronic renal failure, hereditary and acquired hypoparathyroidism, vitamin D deficiency, pseudohypoparathyroidism, and hypomagnesemia. Acute rather than chronic hypocalcemia is seen in critically ill patients or as a consequence of certain medication and often does not require specific treatment. Transient hypocalcemia is seen with severe sepsis, burns, acute kidney injury, and extensive transfusion with citrated blood. Although as many as one-half of patients in an intensive care setting are reported to have calcium concentration of less than 2.1 millimole per liter, most do not have a reduction in ionized calcium. Patients with severe sepsis may have a decrease in ionized calcium, but in other severely ill individuals, hypoalbuminemia is the primary cause of the reduced total calcium concentration. The classification of hypocalcemia is based on the premise that parathyroid hormone is responsible in the regulation of plasma calcium concentration, and therefore that the occurrence of hypocalcemia must mean a failure of the homeostatic action of the parathyroid hormone. Failure of the parathyroid hormone response can occur if there is hereditary or acquired parathyroid gland failure, if a mutant PTH is secreted, or if PTH is ineffective in target organs, or if the action of the hormone is overwhelmed by the loss of calcium from the extracellular fluid at a rate faster than it can be replaced. Neuromuscular and neurologic manifestation of chronic hypocalcemia include muscle spasm, carpopedal spasm, facial grimacing, and in extreme cases, laryngeal spasm and convulsion. Respiratory arrest may also occur. Increased intracranial pressure occurs in some patients with long-standing hypocalcemia, often in association with papilledema. Mental changes include irritability, depression, and psychosis. The QT interval on ECG is prolonged. Arrhythmias or intestinal cramps and chronic malabsorption may likewise occur. Gevostec and trosusine can be used to confirm the latent tetany. Hypoparathyroidism. Acquired hypoparathyroidism secondary to surgery in the neck is still more common than hereditary hypoparathyroidism, but the frequency of surgically induced parathyroid failure has diminished as a result of improved surgical techniques that spare the parathyroid glands and increased use of non-surgical therapy for hyperthyroidism. Acquired hypoparathyroidism can result from inadvertent surgical removal of parathyroid glands. In some instances, not all tissue is removed, but the remainder undergoes vascular supply compromise secondary to fibrosis. Acquired hypoparathyroidism can also result following thyroidectomy. Rare causes include radiation-induced damage subsequent to radioiodine therapy of hyperthyroidism and glandular damage in patients with hemochromatosis or hemosiderosis after repeated blood transfusion. Transient hypoparathyroidism is frequent following surgery for primary hyperparathyroidism. After a variable period of hypoparathyroidism, normal parathyroid function may return due to hyperplasia or recovery of the remaining tissue. Occasionally, recovery occurs months after surgery. The signs and symptoms of hypoparathyroidism is due to hypocalcemia. In hereditary hypoparathyroidism, it presents with a more gradual onset associated with other developmental defects. Extrapyramidal syndromes, papilledema, and lenticular cataract may also be seen. Conventional treatment has involved replacement with vitamin D or calcitriol combined with a high oral calcium intake. For many patients, vitamin D in doses 40,000 to 120,000 units per day combined with more than 1 gram elemental calcium is satisfactory. Oral calcium and vitamin D restore the overall calcium phosphate balance but do not reverse the lowered urinary calcium reabsorption typical of hypoparathyroidism. Therefore, care must be taken to avoid excessive urinary calcium excretion after vitamin D and calcium replacement therapy. Otherwise, nephrocalcinosis and kidney stones can develop and the risk of chronic kidney disease is increased. Thiazide diuretics lower urine calcium by as much as 100 mg per day in hypoparathyroid patients on vitamin D provided they are maintained on a low-sodium diet. Experimental use of parathyroid hormone, the synthetic fragment used in treatment of osteoporosis, showed promise. Subsequently, the full-length molecule of parathyroid hormone has been shown to be effective and is now FDA approved for therapy of hypoparathyroidism. Published reports illustrate that its use substantially reduced the requirements for supplemental calcium and active vitamin D to maintain serum calcium. Severe hypomagnesemia is associated with hypocalcemia, and restoration of the total body magnesium deficit leads to rapid reversal of hypocalcemia. Vitamin D deficiency. 1,25-dihydroxyvitamin D is the major steroid hormone involved in the regulation of mineral ion homeostasis. Vitamin D and its metabolites are hormone and hormone precursors rather than vitamins, since in the proper biologic setting, they can be synthesized endogenously. Vitamin D is synthesized in the skin in response to ultraviolet radiation and is also absorbed from the diet. Once the vitamin D enters the circulation, either through the skin or through the intestine, it undergoes hydroxylation in the liver by a cytochrome P450 oxidase, forming 25-hydroxyvitamin D, which is the major circulating and storage form of vitamin D. A second hydroxylation occurs in the kidney, forming 1,25-dihydroxyvitamin D. A reduction in the serum calcium will lead to the increase in the secretion of parathyroid hormone and so mobilizes the additional calcium from the bone. The parathyroid hormone will promote the synthesis of 1,25-dihydroxyvitamin D in the kidney, which in turn will stimulate the resorption of calcium from the bone and reabsorption of calcium in the intestine and regulates the synthesis of parathyroid hormone by negative feedback. The main function of vitamin D is in the regulation of calcium absorption and homeostasis. 1,25-dihydroxyvitamin D increases the efficiency of intestinal calcium and phosphate absorption. It also has an anti-proliferative effect on parathyroid cells and suppresses the transcription of parathyroid hormone gene. These effects are an important part on the rationale for current therapies directed at preventing and treating hyperparathyroidism associated with renal insufficiency. The clinical syndrome of vitamin D deficiency can be a result of the deficient production of vitamin D in the skin, lack of dietary intake, accelerated loss of vitamin D, impaired vitamin D activation, or resistance to biologic effect of 1,25-dihydroxyvitamin D. Due to the increasing concern in the development of skin cancer and focus on skin protection, sun exposure in a lot of individuals decreases. This contributes to impaired cutaneous production of vitamin D and increased reliance on dietary source of vitamin D. The elderly and the nursing home residents are at particular risk for vitamin D deficiency since both the efficiency of vitamin D synthesis in the skin and the absorption of vitamin D from the intestine decline with age. Certain drugs such as barbiturates, phenytoin, and rifampin can accelerate the inactivation of vitamin D metabolites. Severe liver disease or isoniazid is associated with impaired 25-hydroxylation and can cause vitamin D deficiency. Data from the United States show that the prevalence of vitamin D deficiency in obese children is more than 29%, although the main mechanism on how individual with obesity has vitamin D is poorly understood. The clinical manifestation of vitamin D deficiency are largely a consequence of impaired intestinal calcium absorption. Mild to moderate vitamin D deficiency is asymptomatic. However, long-standing vitamin D deficiency results in hypocalcemia accompanied by secondary hyperparathyroidism. This can also result to impaired bone mineralization, resulting to osteopenia and decreased bone mineral density. It may also cause proximal myopathy. Vitamin D deficiency has been shown to be associated with an increase in overall mortality, including cardiovascular diseases. In the absence of an intercurrent illness, the hypocalcemia associated with the long-standing vitamin D deficiency rarely present with acute symptoms of hypocalcemia such as numbness, tingling, and seizures. Rickets is the softening and weakening of bones in children, usually because of an extreme and prolonged vitamin D deficiency. In children before epiphyseal fusion, the vitamin D deficiency will result in growth retardation associated with an expansion of the growth plate. Osteomalacia results from impaired mineralization of bone matrix protein as a result of hypocalcemia and hypophosphatemia that accompany vitamin D deficiency. Osteomalacia is a feature of long-standing hypophosphatemia which result to bowing of weight-bearing extremities and skeletal fractures. Osteomalacia is a disorder of impaired mineralization of the osteoid, while rickets is a disorder of impaired mineralization of cartilaginous growth plates. Adults have fused growth plates, so they are only affected by osteomalacia. The most specific screening test for vitamin D deficiency is serum 25-hydroxyvitamin D level. The National Academy of Medicine has defined vitamin D sufficiency as a vitamin D level of more than 50 nanomole per liter. Although the normal ranges vary, levels of 25-hydroxyvitamin D less than 37 nanomole per liter are associated with increasing parathyroid hormone levels and lower bone density. This hypocalcemia results in secondary hyperparathyroidism, a homeostatic response that initially maintains serum calcium level at the expense of the skeleton. Due to the PTH-induced increase in bone turnover, alkaline phosphatase levels are often increased. In addition to increasing the bone resorption, the parathyroid hormone will decrease the urinary calcium excretion while promoting phosphaturia, which will result to hypophosphatemia and exaggerates the mineralization defect in the skeleton. In children with vitamin D deficiency, it can show widened expanded growth plate that is characteristic of rickets. After epiphyseal fusion, the main radiologic finding is a decrease in cortical thickness and relative radiolucency of the skeleton. A specific radiologic feature of osteomalacia, whether associated with phosphate wasting or vitamin D deficiency, is pseudofractures or looser zone. As a result, these pseudofractures are usually few millimeters wide, several centimeters long, and are seen particularly in the scapula, the pelvis, and the femoral neck. The recommended daily intake of vitamin D is 600 IU from 1 to 70 years of age and 800 IU for those over 70. This is based on the observation that 800 IU of vitamin D with calcium supplementation decreases the risk of hip fractures in elderly women. In patients in whom 1-alpha hydroxylation is impaired, the metabolites that do not require this activation step are the treatment of choice. They include the 1,25-dihydroxyvitamin D3 and the 1-alpha hydroxyvitamin D2. Calcium supplementation should include 1.5 to 2 grams per day of elemental calcium. For those with severe vitamin D deficiency, 50,000 IU weekly for 3 to 12 weeks followed by maintenance therapy of 800 IU daily is recommended. The most efficacious method for monitoring treatment and resolution of vitamin D deficiency are serum and urinary calcium measurement. The 24-hour urinary calcium excretion should be in the normal range of 100 to 250 mg per 24 hour. Normocalcemia is usually observed within 1 week after institution of therapy, although increases in PTH and alkaline phosphatase levels may persist for 3 to 6 months.